Good morning, class. We're going to try this one more time. If it does not work this time, then I will send you something. We're going to start out with Chapter 48. I'm going to hold you responsible for studying the chapter. It's basic anatomy and physiology. There are a few points that I wanted to make on this chapter. It's very important that you work on your assessment skills for these patients. You need to start with a complete history and physical. You want to start with that chief complaint. In other words, what compelled that patient to seek medical help today. Look at their past medical history for chronic problems like diabetes. I'm sorry, let me pull the PowerPoint up for you. Okay, like I was saying, you want to look at the chronic problems like diabetes, sickle cell anemia. Do they have systemic lupus erythemus and these diagnoses, and recognizing them can help you diagnose the presenting symptoms. You want to look at their social and their psychosocial history. It reveals their lifestyles, what smoking or alcohol, if they use that, what type of diet they adhere to, what type of exercise program. It helps you to distinguish. There's a great big difference between somebody that runs and jogs daily to somebody that has a very sedentary lifestyle that likes to sit and play games on their cell phone or on their computers every day. You need to look at the age, the gender, and the culture. And when we're talking about culture, we're not just talking about they're Southern or they're from Pakistan or their Islamic culture. What are their beliefs on their health? What are their dietary considerations? How do they feel about their overall lifestyle? This is part of their culture. How were they brought up? Were they brought up to seek medical help, or were they brought up to be very stoic? And then you also need to know about their educational background. This helps you to narrow down your questions and how you are going to ask those questions. It also narrows down what happened to the person prior to the injury and how that injury may have occurred. You want to also assess how they cope with past histories, past injuries, and past surgeries. That will help you determine how well the patient is going to cope with their present illness. As you're assessing them, you want to watch for those nonverbal cues as well. The main parts of the assessment that you're going to be using will be your inspection and your palpation. Of course, you're going to inspect the skin color. You're going to check for scars, shape, deformities. You want to check for muscle atrophy, and of course, in order to do this, you're going to have to compare side to side. Check for masses and swelling. You also want to be very cognizant of any fasciculations or tremors, because this can indicate if they have a muscular disorder going on. If they have swelling, you want to assess that site and the shape, and you want to check for your standard signs and symptoms of inflammation, such as redness, swelling. Assess for alignment, especially if you are suspicious that the patient might have a dislocation, because in dislocations they can be severely displaced, or they can just be slightly displaced and have a normal appearance outside. So you're going to want to follow this with palpation, checking for tenderness, warmth, nodules, and boggy feelings. You need to look at the chart on page 1471. It tells you how to grade your muscle strength, and this is very important for nurses. At this stage in your education, you should be able to grade muscles on your assessments instead of telling me that they are within normal limits, because what's normal for you and normal for me are two different things. What's normal for a 30-year-old and normal for an 80-year-old are two different things. Okay? If you have a patient that has an affected area, he comes in complaining with his leg hurting, and you go in and you start your assessment, and you notice that his leg looks a little pale, and then you start in with your palpation, and as you touch it you feel that it's a little cool. What's the next step that you want to do? Well, what you would want to assess next would be the distal pulses from that area. You want to make sure that there is blood flow to that extremity. When you are seeing them in the ER or even in the doctor's office, and you're assessing them and you note one that has a cool or pale extremity, you would anticipate that the doctor would send them for CTs or MRIs. So please make sure that you know what you need to be teaching and assessing on these patients before they go down for such a procedure, such as with a CAT scan. You're going to want to assess to make sure that they don't have any allergies to shellfish or something like that if they're going to give them a dye. Or if it's an MRI, you're going to want to make sure that those patients don't have any metal objects. You want to not only on their body but in their body. One thing that a lot of nurses tend to forget about are partials on dentures. They have metal on them, and they can literally be pulled out of their head while they're getting an MRI. Okay, now this is all that I wanted to talk to you about on chapter 48. So let's go to chapter 49, or excuse me, I'm going to go to 51. We're going to talk about the arthritises and connective tissue disorders, if you'll bear with me for just a second. Okay, for testing purposes, I didn't go real heavy into the arthritises, but you do need to know about each specific arthritis. Please get your books and make sure that you look at each one of them as far as the pathophysiology standpoint goes. You want to look at the medications. You want to also look at the labs and the diagnostic testings that these patients undergo. On the medications, you want to make sure that you are well versed in the action of the medication. That will help you determine what labs you need to look for as far as the patient receiving medication. You're also going to want to be well versed in your interventions for these patients. Most arthritises have the same interventions. Medications will be a little different, but your non-pharmacological will be the same. You're going to apply heat to decrease muscle spasms. You're going to apply cold to reduce inflammation and pain in these patients. The surgeries will only be performed if they would be to the advantage of the patient, if it's going to increase their actual ability to live their life. Okay, it might be a synovectomy or an athrodesis or a reconstructive surgery of some type, and as I said, this would just improve their lifestyle. Your nursing management, of course, you're going to focus on pain management for these adults and children. Contracture prevention is very important. Fall prevention and fall precautions are very important. You want to educate them on their exercise program, balancing rest and activity, dietary considerations, and educate the patient on their disease process. The care plan on page 1573 through 1575 is very good. It also has a box there for discharge teaching that you need to be familiar with for these patients. Now, osteoarthritis is our first one. They get up with morning stiffness. They may have complaints of pain with movement of the joint. They have fatigue, generalized weakness, anorexia, and cold intolerance. They will have large joints. They'll have limited movement with advancement. One thing that sets osteoarthritis, apart from some of the others, is that the skin is very shiny and very stretched, and they have subcutaneous nodules. Diagnosing these patients will be on clinical impressions. The doctor will take consideration their age and history and their physical exam. They will do bone mineral density tests, their ESR and their RA factors will also be examined. They'll do x-rays, CTs, and MRIs. Rheumatoid arthritis. They experience remission and exacerbation. They do have fatigue. These patients can have low-grade fevers. And when I say low-grade fevers, they can maintain a low-grade fever every day of their life. I have a daughter that has been diagnosed with rheumatoid arthritis. She's 35 right now. She was diagnosed when she was 7, and her normal body temperature is over 100. It fluctuates between 100 and 101. They also tend to be anorexic. They have joint pain and swelling due to inflammation. It can be symmetrical joint deformities. They have crepitus. They can have swollen glands, dry mouth. They can have nodules in the lungs. It doesn't just necessarily maintain itself to the bones and the joints. They can have them in the lungs and the kidneys. You're going to see a decrease in the red blood cell and white blood cell counts, and they do tend to have tissue necrosis at times, especially if it's very advanced and their bones start crumbling. They will literally crumble into little bitty pieces that will work their way out through the skin. Diagnosis for these patients, you're going to see a positive RA factor. Their ANA and their anticriptoline will be elevated along with the ESR, and they will show bone changes on x-rays. It is incurable. The medical management for these patients focuses more on the treatment of symptoms. They are treated with NSAIDs, corticosteroids, and anti-neoplastics and anti-malarials. Your book on page 1567 goes into each one of these. As I said before, you want to know that the mechanism of action, and your book gives you the action on each one of them. Such as you will see them being given ibuprofen or Motrin or Solenodac, and these are anti-inflammatories. Their analgesic action, they inhibit the prostaglandin synthesis, okay, of inflammation. They can also be given Celebrex, which is a COX-2 inhibitor, methotrexate, which is an anti-neoplastic. And they can be given immunosuppressants, and Cytoxan, which is a cyclophosphamide. You want to ensure that these patients have a good balance between rest and exercise. You want to make sure that they safeguard their joints. When I say exercise, they need a moderate exercise program, but it needs to be exercises that are not stressful to the joints, and that holds true for all arthritis patients. So you would want them to be walking, instead of running. You would want them to be swimming in a pool instead of horseback riding, that type of thing. Aquatherapy is very good for patients with arthritis because it puts absolutely no stress on the joints, and especially if the water is warm, it also helps with that joint movement. Okay, you're going to monitor them for pain. You also want to monitor their lab work very closely. You want to ensure that they are very cognizant of fall precautions, especially in their home. You would need to review these with the patient, and there's an excellent portion in your book on patient teaching for these types of patients as far as home goes and fall precautions. Rest and exercise and dietary teaching is also needed for these patients. Now let's talk about psoriatic arthritis. Psoriatic arthritis is one of the newer ones that you hear quite a bit about lately. It's pain. They have pain with the diagnosis of psoriasis. That is the defining characteristic of a psoriatic arthritis is that they have the psoriasis to go right along with it. Okay, their pain and stiffness in the affected joints can be alleviated with physical activity. They can present with polyarthritis and osteoarthritis and distal arthritis. Okay, soft tissue inflammation. They also have the dactylus, or the sausage digit fingers. In other words, their fingers look like little sausages. Okay, they have pits in their nail plates as well. There's no specific lab work to diagnose this. About a third of them will have an elevated sedimentation rate. They do x-rays show erosive changes, and MRIs will show inflammation in the bone marrow and the soft tissues of these patients. Okay, medications, they're going to get the NSAIDs and the COX-2 inhibitors, non-selective NSAIDs. They're going to get the anti-ulcerative medications. Now, why would they put these patients on anti-ulceratives? Of course, it's because of the NSAIDs that they're getting. They get large doses of NSAIDs. Disease modification, they can get anti-rheumatic drugs and also anti-TNF medications. Your nursing management is going to have to deal with early detection, pain relief, and of course protection of those joints. You're going to need to educate these patients extensively on adherence and compliance to their medical regime that the doctor has put them on. Gouty arthritis, there's 4 stages. You've got the asymptomatic, which has an elevated uric acid level, and that's basically it. They have no other symptoms. You can have acute episodes where they'll have an increase in that uric acid level. They can have topy in the joints and in the earlobes. They'll have sudden onset of pain. Most of the pain is at night. Let's see. Heat in the area, inflammation, swelling. You need to teach these patients that consumption of alcohol and drugs can cause a flare-up that can last 3 to 10 days. Then they can go in. Also, you will have some that will go into intervals or conditions that are called remissions. Diagnoses, you're going to check your uric acid level, do x-rays, and joint aspiration is the definitive diagnosis. Now, the medications for these are on page 1567 as well. Each one of these chapters just has one large table for the medications for all of these diseases, so you need to be familiar with those. You're going to monitor that uric acid level. You want to teach your patients to maintain a diet that's low in purines. So what does that mean? Of course, it means a moderate amount of protein. They should decrease their alcohol intake and eliminate beer altogether because it is high in purines. Okay, I've given you a list here on the slide of some of the foods that they need to avoid. If don't be surprised if you see some questions that might have some diets on them, and which one would be a diet that would be appropriate for someone with gouty arthritis or something like that. You also need to look at the evidence-based box and national guidelines on page 1578 for the treatment of gouty arthritis and how to reduce incidence of gouty arthritis. Now let's move on to reactive arthritis. You will see inflammation in the joints, entheresis, axial skeletal involvement. It can also involve the GI tract, conjunctivitis. You have unilateral uveitis. They can have circinate bantus of the penile, gland, asymmetrical joint swelling in the lower extremities. Reactive arthritis is arthritis that stems from a reaction of some type of infection. So as you can see from all of the list of signs and symptoms, that it could take place anywhere in the body and cause massive problems in these patients. Diagnosis, there's no specific lab diagnostics for this. It's based on recognition of the combination of arthritis and inflammation. Most of these patients will demonstrate an inflammation in the eyes or the genitalia and the urinary and or the GI system. Okay, look at your labs on page 1579. Your ESR is going to be elevated, and then your C-reactive proteins, or your CRP, will also be elevated in these patients. Medical management, they're going to be symptom control and prevention. You're going to have the NSAIDs, glucocorticoids, topical glucocorticoids for the penile problems and the conjunctival problems, eye problems. They're going to have anti-infectives, immunosuppressants, and tumor necrosis factor inhibitors will be given. Of course, like I've said numerous times now, know the pharmacy or pharmacological stuff on page 1567. Range of motion exercises and hydrotherapies are very important for these patients. Your nursing management, you're going to monitor their pain in their lab work. You're going to medicate them as ordered. You're going to start them on an exercise program, and you want to teach them those fall precautions. You want to teach them dietary considerations and compliance with that medical regime. Now let's talk about ankylosing spondylosis. This is actually arthritis in the backbone. You're going to see weight loss, fatigue, fever, diarrhea. They complain of eye pain and photophobia as well. You can have an increased number of GI and urinary tract infections. They complain of low back pain, morning stiffness, loss of flexibility in the lumbar spine, and they can have restriction in their ribs. They can also have involvement of their heart valves. Okay, diagnostics is going to be an elevated ESR, a CRP, and a HLA-B27. They're also going to do x-rays and bone scans of these patients. It is highly important for early detection in these. Medications, you're going to be given NSAIDs and methotrexate. They need a strict balance between rest and activities throughout the day. So you as a nurse, you're going to monitor their pain and their lab work. You're going to administer the medications that are ordered. You're going to teach them a balance, and as you are caring for them, you're going to segment your nursing care to provide them plenty of rest in between activities. Okay? Teach them the importance of their diet and exercise and their medical regime compliance. Now let's talk about septic arthritis. Septic arthritis is single swollen or painful joints. They can have systemic chills. You will see this in patients that are over 80. They have rheumatoid arthritis, diabetes, and skin infections. And the skin infections will be mostly with the Staph aureus. Okay. A common source of these infections will be intravenous drug use and indwelling catheters, and underlying immunocompromised states like your HIV. Diagnosis is going to be a culture of the synovial fluid in the joint by aspiration, needle aspiration. They will be placed on broad-spectrum antibiotics, IV, for a couple of weeks. It typically is broad-spectrum until they identify the agent, and then they will put them on a specific antibiotic, of course, like every other infection. They can be on the IV antibiotics for 2 weeks and then be switched to oral for a total of 3 to 4 weeks, and they will also be given antipyretics to control their temperature. You need to start these patients after they start responding to the antibiotics on a progressive range of motion exercise. Early recognition of what is going on in your patient and pain relief and joint protection from damage is your main nursing management and nursing considerations for these patients. Now let's talk about connective tissue disorders. And we only have a few of these to talk about. Your systemic lupus erythemus. These patients show weakness. They have sensitivity to light. They are very sensitive to pain, minor pain, or a minor injury causes severe pain. They have elevated temps. They have that typical butterfly rash on their face and their palms, and they can have Raynaud's like disease symptoms, weight loss. They can have or display dysfunction in one or more organs, ulcerations in the mouth and the nasopharyngeal areas, headaches, irritability, and of course these patients do suffer from depression. Your diagnosis, you're going to see lupus erythemus prep and an ANA. They're going to have anti-DNA and anti-SM bodies, all performed for them. Serum complement testing with complement proteins C3 and C4. Medical management, they're going to have, in mild cases, they'll do intermittent NSAIDs, and in advanced cases, they're going to do the NSAIDs and corticosteroids and antimalarials. Immunosuppressives will be given to the more severe cases, and the rituximab is the newest medication, and it shows benefits for those patients with lupus. They can also do plasmapheresis and dialysis on these patients to pull the serum complements off of the blood, okay, to help decrease the extent of their episodes. Your nursing management, you want to teach these patients about the reduction of injuries and how to control their discomfort. It's very important to teach them the balancing rest and activities, maintaining their skin integrity. You want to have them wash with mild soaps and use mild lotions. They need to make sure that they reduce ulcerations in their mouth, so they need to keep a close eye on that. Improving their diet and their fluid volume. They need to drink plenty of fluids, and also it would benefit them if you would start them in something like yoga or meditation, massage therapy, something that will help decrease their anxiety and their depressive level. And of course, you need to teach them about staying compliant with their medical regime. Scleroderma is the next one that we're going to talk about. Scleroderma is With scleroderma, the immune system stimulates the production of excessive amount of fibroblast. It can involve any of these systems, like your skin, circulatory joints, your bowels, your cardiac and respiratory, and your renal. Okay? CREST identifies a group of symptoms, C-R-E-S-T. The C stands for calcium deposits in the organs. The R stands for your Raynaud's type symptoms that these patients will exhibit. E stands for esophageal dysfunction. S stands for your sclerodilactis, which is a thickening and tightening in the skin of the fingers. And the T stands for the telangiectasis, which is a vascular lesions formed by dilation. Okay? Your medical management is going to, your diagnosis is going to be based on your clinical manifestations. They'll do x-rays, lung function tests on these patients. They'll do CT scans and ECGs, and they may do a heart cath to evaluate the pressure in the arteries of the hearts and the lungs. Okay? Medical management is going to focus on symptom control. They're going to have corticosteroids, salicylate, and or narcotics, immunosuppressants. You can see nifride and nicardipine and topical nitro, SSRIs, omeprazole, antacids, prednisones, methotrexate. You'll want to keep their hands warm and protected. These patients should avoid caffeine and smoking, and they may do laser therapy for that telangiectasis to minimize, and they need to minimize their sun exposure to scleroderma. So they need a very high-powered SPFs when they go out. You need to be teaching them about this, and they need to wear long sleeves, hats, the whole works. They also need the mild soap and lotion, and they may need some help with psychiatric help as far as dealing with the changes in body image and just the restrictions to their lifestyle. You as a nurse need to allow them plenty of time to verbalize their feelings. Now let's talk about Lyme's disease. You should have already gone over Lyme's disease with Miss Lindsay in the emergency, but I want to touch on it just a little bit, just in case she didn't get it all. There is a chart, 51-2 on page 1587, that gives you the signs and symptoms for each level of Lyme's disease. There are 3 levels. Your early localized, which is days to 1 month after the bite. Your early disseminated, which is days to 10 months after that bite, and then your late or chronic disease, which is months to years after the bite. Please be familiar with this chart. Diagnosis is your lab work, and antibodies for Lyme disease will be positive. In the early stages, they will provide antibiotics. Standard antibiotics would be doxycycline for adults and kids over the age of 8, amoxicillin for older adults or younger kids, and pregnant women and breastfeeding. Okay? Early dissemination, disseminated stage, they will have IV antibiotics for 14 to 28 days, and they'll also receive antipyretics and NSAIDs. Your nursing management is going to depend on what stage they are in. Early stages, they are treated with flu-like symptoms. Later will depend on the systems that are involved, be it the heart, the lungs, whatever, the kidneys. Educate them on the disease processes and prevention and medications and complications. So what are these? Well, this obviously not going out into the woods without being well covered, tucking your pant legs down in your boots, the use of DEET, sprays, staying on the trails, making sure that you assess your body frequently for ticks, and removing them properly when they are found and promptly. Now let's talk about Sjögren's syndrome. It's an autoimmune disease. It's causing inflammation of the glands that produce tears, so your lacrimal glands, leads to decreased water production for tears, and you'll have eye dryness. Inflammation of the glands that produce the saliva in the mouth can also be affected. It leads to mouth dryness. Sjögren's syndrome is not considered a connective tissue disease when it involves the glands affecting the eyes and the mouth only. However, it is when it is associated with rheumatoid arthritis. Your clinical signs and symptoms, of course, dry eye, dry mouth, they're the hallmark. You can see renal stones, tubular acidosis, hypokalemia. You'll have interstitial nephritis, GI, you can see dysphagia, persistent dry coughs, orthostatic symptoms. Diagnosis, you're going to have an elevated ANA, SA, SSB, an RA factor, and an ESR, and your immunoglobulins. Schinner's test, and excuse my slide, I have one too many H's in there. They're going to test the parotid gland flow, and they can do the saliva as well. X-ray the salivary ducts system, and they can do lip biopsies. Moisture replacement therapy is given. The Biotene that you see advertised on TV, increase fluid intakes, give them oral sprays. Chewing sugarless gum also helps. You want to make sure that they wear sunglasses to protect their eyes outside during the day. They do not need to sleep under a fan at night because this is very drying as well. NSAIDs, corticosteroids, and immunosuppressive drugs will be given to these patients. You need to make sure that you protect your nursing management, protect the affected tissue, and prevent complications. You want to avoid irritation and monitor for signs and symptoms of infection. Okay? And that is all for this one. I hope that helped you some. If you will, just try focusing on your pathophysiology, your mechanism of action in your medications, your nursing interventions, and this should help you in dealing with these. Just give me a brief second to make sure that I'm trying to make sure I cover every question that is on your test with you. I think I have gotten it all, and I hope this saves for you and that you do well on the test. Thank you.